policymakers, and all other interested parties to learn and share about community development, especially topics that are really core to the work of community development, like that which we will discuss today, which is the intersection of health and housing. Before we get started, just a few notes on logistics for this morning's conversation. First, please note that we are recording this session as we intend to share it with folks who may not be able to join us this morning. Second, if you have any questions or comments while one of our panelists is speaking this morning, please feel free to leave it in the chat and we'll try to incorporate it into the discussion. There will also be an opportunity for open Q&A towards the end of the conversation this morning, so you can also hold it till then if you like. Third, if you hear a word or a phrase that you are not familiar with, we encourage you to note that in the chat. My colleague, Ali Steinberg, who is with us this morning, will be watching the chat and we'll jump in to explain or translate as best as we're able. This is a space for learning, so we encourage you to use it as such. And fourth and finally, just really excited by the folks who have RSVP'd for today's session and just would love to have a sense of who's in the room. So if you don't mind taking a moment to introduce yourself in the chat, your name, something about what you're affiliated with or what brought you to today's conversation, whatever you're happy to share, but would love to see those popping up in the chat as we get started here. So today, as we noted, it's a special and extended of Fresh Fridays, which is focused on the economics of health and housing. So featured in today's session, we are going to share the results of a recently completed study of One Neighborhood Builders' permanent supportive housing program. This independent study, which was completed by Faulkner Consulting Group, investigated the impact of our program on the utilization and cost of healthcare for previously homeless individuals and families who have been served. So we'll have an opportunity to talk about the results, their implications for Rhode Island and the broader field, and what next steps we might collectively take to continue advancing health and housing solutions for our fellow Rhode Islanders. So we're joined by esteemed partners and guests, each of whom you will hear from today, and then they will, of course, stick around to answer some questions. So I'm going to introduce each guest in just a few minutes, but before we do that, I'd like to hand it over to Jennifer Hawkins, President and Executive Director of One Neighborhood Builders, to provide some opening remarks. Jen?
Thank you, Grace. Good morning. This is our one-year anniversary, I think, of Fresh Fridays, and we have a record-breaking number of participants, so it's excellent to see so many interested individuals. So, this is a very timely and important topic, the economics of health and housing. So for those, I think you're all familiar, but just in case some of you may not be, One Neighborhood Builders is a community development leader in Rhode Island. In our history, we have developed nearly 600 units of affordable homes for families in Greater Providence. And as you might know, we are also the convener of the Central Providence Opportunities Health Equity Zone, a collective impact comprehensive initiative based in the Central Providence area. And we also aim to influence policy and change systems towards advancing our mission of cultivating healthy, vibrant, and safe communities. So as part of this work, especially this influencing and systems change component of our mission, we're committed to sharing the examples of the work that we do and contributing to ending homelessness. So we pledge to commit 10% of our units as permanent supportive housing. And as some of you might be aware, there's an initiative that we are developing in East Providence called the Taunton Avenue Collaborative, which will go well beyond that 10% commitment. In fact, we're planning on setting aside 40% of our homes there as permanent supportive housing. So many people ask, what exactly is permanent supportive housing? In its most simple definition, it is combining permanent housing, not transitional or shelter, with a rental subsidy and supportive services that allow people to maintain their lease compliance and enjoy stable housing. It actually can be applied to a range of different populations, individuals who have aged out of foster care, individuals who have recently been incarcerated, individuals who experience homelessness. The specific population of individuals that we are going to be discussing today and in our report is permanent supportive housing for households who've experienced chronic homelessness and receive services and a rental subsidy to ensure they remain stably housed. So we've actually been committed to this work for a number of years. That is connecting individuals who experience homelessness with behavioral and mental health challenges and other barriers to housing to permanent housing. But in 2019, we received a contract from Rhode Island Housing's Continuum of Care program to provide PSH, permanent supportive housing, to individuals on Rhode Island's coordinated entry list. So the coordinated entry list is the sort of one single funnel that records individuals based on their length of homelessness and their vulnerability, and sort of ranks individuals, if you will, according to those metrics, so that we're ensuring that individuals who are most vulnerable, most chronic, are receiving housing first. So we're really taking the, you wouldn't, potentially say the hardest to house, and placing those individuals into housing first. So we were partnering with Rhode Island Housing in this program and developed a relationship with Providence Community Health Centers to provide the services for those individuals. So even before the launch of this partnership in 2019, we really had a hunch that those that we house and connect with necessary healthcare ultimately save our health systems money by shifting costs away from emergency care into preventative and behavioral health care. We've seen this result in studies implemented across the country, and there really is solid evidence demonstrating that housing is an investment worth making. However, until now, this kind of study had not been completed in Rhode Island. So because we really understand the importance of learning from our work and sharing these learnings with the field, we commissioned this independent study that you'll hear more about through Faulkner Associates. And it really aims to understand the impact of our permanent supportive housing program on the utilization and cost of healthcare for previously homeless individuals and families. So I saw a couple questions in the chat about having a link to the report. After this Fresh Friday, we will send the final report and you will see all of the information firsthand. But spoiler alert, this housing, permanent supportive housing, does save Medicaid money. So, and we can demonstrate that. So I'm really excited that you're all here and to share the findings with you. So hitting it back to Grace.
Thanks very much, Jen. I'd now like to bring in our partners who helped in executing this study, and they can give you a much more scientific takeaways than our shorthand spoiler that Jen led us off with. So first, I'd like to introduce Deb Faulkner and Grant Porter of the Faulkner Consulting Group, who led the independent study that we're going to discuss today. So Deb is the founder and president of Faulkner Consulting Group. And for over 15 years, she's advised and participated in Rhode Island health policy and program design. She's consulted with several local and regional health insurers and government agencies on issues including of the Affordable Care Act implementation, Medicaid program design, and health plan and provider regulation. They have also worked at Rhode Island's Health Benefits Exchange, Health Source Rhode Island. I'm going to come off mute for a second, Deb, and just say hello.
Hi, everyone. Thank you for having me.
Grant Porter, also of the Faulkner Consulting Group, is a senior consultant. He has vast experience in the technical, analytical, and political aspects of health policy and has provided direct support to Rhode Island's Office of Health and Human Services and the Office of Management and Budget since 2014. And he also served as the lead researcher on this study. Grant, thanks for joining us.
Thanks, Grace and Jen. Pleasure to be here.
Next, I'd like to introduce Tom Douglas, the Director of Finance for ACO at Providence Community Health Centers. PCHC is the service provider partner for our permanent supportive housing program, as Jen mentioned. Tom specializes in Medicare Advantage and commercial market risk adjustment and came to PCHC from a career at Blue Cross Blue Shield of Rhode Island. Good morning, Tom.
Good morning. Thank you, everyone. Glad to be here.
And I'd like to introduce our final guest this morning, Chris Kohler, president of Millbank Memorial Fund. Chris was not involved in this study. However, he brings a wealth of knowledge and experience at the intersection of health and housing, as well as opportunities for creatively using public dollars to improve health outcomes. From 2005 to 2013, Chris served Rhode Island as the country's first health insurance commissioner, and his office was nationally recognized for its review process and its efforts to use insurance regulation to promote payment reform, and was one of the leading agencies in implementing the Affordable Care Act in Rhode Island. Before his tenure as the state health insurance commissioner, Chris was the CEO for Neighborhood Health Plan of Rhode Island, and also serves as an adjunct professor of community health at the School of Public Health at Brown University. Hi, Chris.
Good morning, everybody. Sorry to take up that time with that windy intro.
Well, appreciate you and all of our guests joining us this morning. And now we're going to transition to walking through a short presentation that aims to provide some of the key takeaways from the assessment we've been talking about this morning. Please note that the slides we're showing here are not the entirety of the report. As Jen noted, we will be sharing that entire report coming out of today's conversation. And the hope here really is to just give a high level of some of the key takeaways and then have a broader discussion about what this tells us about our work more broadly. So I'm going to pass it back to Jen, who will kick us off with a little bit about the study's purpose and design.
Thanks, Grace. So, this actually was a long time in the making, I have to say. We originally considered the idea of a study probably about 18 months ago. And after determining that we needed a third party to do this, we considered the field, and it was clear that there was only one group that we wanted to work with, and that was Faulkner Associates. And they kindly agreed to take on this little project for us. And we, in discussions with them, determined we needed to obtain Medicaid data from Executive Office of Health and Human Services. So I really want to acknowledge the collaboration that we had with the Office of Medicaid and EOHHS to provide Faulkner with the data. It didn't come to us, it was directly to Faulkner, and the partnership with PCHC. So really it was this group effort of really deciding that this critical inquiry was worth the effort. So as I mentioned, but just I think it warrants repeating, the Continuum of Care program is a national program. It is a HUD, Housing and Urban Development program, that Rhode Island Housing here in Rhode Island is the entity that implements it here. And so it's specifically for its permanent supportive housing for individuals who are experiencing homelessness and have high medical and behavioral health needs. And so we wanted to look at the Medicaid claim data of 3 populations. And so in the report, you'll see, in some of the data slides you'll see in a moment, there are 3 categories. We're comparing shelter stays. So that's individuals who are residing, who are unhoused or are in shelters, with individuals who are in COC, meaning they are the individuals who are living in one neighborhood builder's apartments and receiving services by Providence Community Health Centers. And the third category are just straight Medicaid individuals in Rhode Island. So all other AE, as it's referred to as all other accountable entities. So those are the 3 categories of comparative groups. I think we can go to the next slide. So the bottom line, if you will, or the major takeaway is that the average Medicaid-related healthcare spending for persons who were formerly homeless and who are now living in One Neighborhood Builders permanent supportive housing was consistently lower than Medicaid recipients who continue to experience homelessness. That is the ultimate takeaway, and I think something that's worth kind of diving into more, and that's what we'll do now. So there's 4 takeaways that we're going to go through, and after each takeaway, I'm going to hand it over to Deb, who will provide a little more analysis. I'm going to only provide the very kind of layman's terms here. So the first one was that Medicaid costs were 43% lower among Rhode Island's Medicaid members who had access to our permanent supportive housing. So those about 16 individuals, compared with other Medicaid members who remain in shelters. And this little grid over here kind of shows that, right? So the overall cost per member per month for COC, that's the people who are living in 1MB's housing, was about $1,200 per month, compared to those similar individuals who are still in shelter, over $2,000 per month. So that's the difference. And then all other AE adults is everyone else who is on Medicaid. So I think that Deb can probably dig into that a little bit more in the next slide.
Great. Thanks, Jennifer. So Jennifer explained, Jen explained all of the basic components. Let me just ground you in this slide a little bit, and then I'll give a little more detail. So remember what Jen said, there were 3 categories: the continuum of care participants, that's the green, that's the teal column; the shelter stay group, that's our control group, that's the blue column; and the all accountable entity, the general group, that's the gray column. The numbers Jen was citing on the prior slide is that far right column. That's the combined 2021, 2022 with inflation adjuster. That's looking overall for the period of study. What was the total cost per member of the control group, the shelter stay, the blue column, versus the continuum of care group, the teal column? And those results are substantive, right? You can see $2,000 per member for the shelter stay. These populations are complicated. They use a lot of Medicaid services. They're expensive. You look at the continuum of care group, substantively reduced, 43% lower for that period of time, right? Still a high cost population. We have to note, like, this is a population that's complicated. They're expensive. They use a lot of services, but the utilization and the service, and you're going to see, we're going to peel the onion about where and how these costs are substantially lower for the population that's being served by this program. Now, I have to say the caveat, it's 16 people, right? It is a small sample, a small program, but the results are notable, even with that size limitation, and sort of good for conversation as we move forward.
Thank you.
Or turn it back.
Thank you. So then the second takeaway is that, you know, Medicaid spending on hospital services and pharmaceuticals was 51% lower among those individuals who are living in our permanent supportive housing compared with those individuals who remain in shelter. So hospital services is particularly interesting, I think. I previously worked in New York City, and we did a similar study like this nearly 20 years ago, actually. And, you know, we were finding that individuals who are experiencing homelessness use hospitals as sort of de facto shelter. And I think that this is, if you speak with outreach workers and individuals who work with homeless individuals in the street, especially unsheltered homeless, that is the truth, right? That hospitals in many ways are a last resort for individuals. And so this spending specifically around hospital services is notable. And I'm going to let Deb dig into this slide, the next slide as well.
Yeah, I love this slide because I think it's then the next one with the numbers on it, but because I'm a numbers person, but I love this slide because I think it shows where are we spending money? And I think Chris Kohler will love this too. It's always the place that we say, gee, we're spending so much on inpatient services and pharmacy and not enough in the community, that middle section, that professional areas. That's something that, you know, a lot of folks say we've really got to rebalance. And that imbalance is even higher for the reasons Jen just said. For these populations, they're using the hospital, right, a lot. And that is the challenge here, is how do we change that? How do you shift that? How do you get folks the services they need in the community and not in an inpatient setting, not have them end up in the hospital? And what's so notable about this is that the savings occur in the areas you want and increase in the areas you want, right? And so what you see here are substantive reductions on the left side in inpatient expenditures, and we're going to show later in utilization. And similarly, you don't see substantive reductions in, we're going to show in the community mental health facility in the CMHOs. And that's great news, right? Because that would suggest this program's kind of doing what it's supposed to do. It's keeping people out of the hospital or reducing hospital utilization. And I will say those numbers are so big, which means the Medicaid savings opportunity is large, right? Usually you're trying to justify expenditures with hospital utilization or ED utilization that's small, and therefore the savings are small. In this instance, because this population uses the hospital and ED so much, there's a lot of expenditure there. And so that reduction is very meaningful in inpatient utilization. I'll pause there. I think that's.
In fact, that then, you know, the next takeaway is pretty much, is a perfect segue, and it is just further validating this reduction. This is a specific investigation around emergency department utilization. And there you see it's really, you know, 50% less emergency department utilization. So beyond just like kind of hospital and pharmaceuticals, also specifically around the ED. And I think this is notable, you know, during COVID, we recognized that the emergency department was inundated, right? And there was a real concern that we had to flatten the curve, right? Because really concerned that we could not manage the influx of individuals who are coming into the hospital. And so recognizing the stress that EDs in Rhode Island are experiencing, I think this is a particularly notable finding. And you can go to the next slide and pick it back together again.
Yeah. And notable, not just so you can see here, this is the utilization. The prior slide was showing the costs. It tells the same story. This is now on the use of the services, not just on the cost of the services. And what you see here is the left is inpatient, it's small font, sorry folks, but the left, the smallest, the left side is the inpatient, then the next set of columns is the ED visits, then PCP visits, and then CMHO, that's the community mental health centers. That's where a lot of these services are being provided. And what you see is kind of, like I said before, what you want to see. Inpatient utilization is lower, ED visits is way lower, and CMHO using services in the community is up. Now, again, small sample size, 16 people, got to keep caveating that, right? It's important to understand this is, you know, very, very small, but the results are notable and I would say timely, right? Because it happened fairly quickly in that we're talking about 2021, 2022, you already see substantive change or differences in the behaviors of this population versus the control group.
Thank you. And you know, as Deb just mentioned about the, you know, the increase in CHMO, this is a positive change that we want to see. And I think it really does speak to the fact that what we're seeing is that individuals who are unhoused have a much greater acuity of behavioral health and mental health needs compared to the overall Medicaid population. In fact, you know, those who have a presence of substance use condition have 3.5 times more likely to have behavioral health needs. So it's a very an acute population, but those costs or treatment associated with those diagnoses are more appropriate in a CHMO than an emergency room. And that's really what we're seeing.
Yeah. And what's important here, I think on two dimensions here, I'd say, first, I would say it appears you're serving the right people, right? These are the complicated populations. They're 3.5 times more likely to have a serious persistent mental illness. They are not just that. The other dimensions we looked at was just general behavioral health needs. So mental health utilization or mental health diagnoses, substance abuse, substance use diagnoses, all of that were very high for these populations, right? These are complicated people that need a lot of services, right? And so you are reaching the right folks, it appears, with this program. But the second thing that's really important is the first thing people are going to say when you look at a study like this is, all right, well, how'd you do your control group? And is it really a comparable group? And I was struck by how comparable they were, right? We took out, I want to say, the folks that were not in shelters, so living on the streets, in part because their results in this small sample were just too volatile. They were too variable to use, and the shelter stay seemed cleaner to compare. But when you compare these populations, they have very similar. You can see those stats on the high acuity. You see the same comparison. 70 to 80% of these populations, both for the shelter stay and the community of care population, have a behavioral health diagnosis of some sort, and the numbers are very comparable for the shelter stay, for the community and the community of care populations. So it gave us confidence, as much confidence as you can have in 16 people, right? Some confidence that the results seemed reasonable.
Wonderful. Thank you, Jen and Deb, for walking us through some of these high-level takeaways from the study. As we transition to a broader discussion, I want to flag one question that was in the chat that I thought maybe Deb or Grant could speak to, which is just about the demographics of the COC group study. So if you mind chiming in on that front?
I would love to pass that to Grant. Grant,
Sure.
you want to tackle that?
Yeah, we have limited demographic information in the full report due to the sample size. We couldn't we could peel back that onion too much. But in terms of age, their age is comparable to the control group. We did exclude children from the study. So the 16 participants, those represent the head of households and not the children, just because of the limited sample size, and weren't able to look specifically at the children. But we do have some additional information on whether they're adults or households, and gender breakdown and age groups.
Thank you, Grant. And yes, many more details in the full report, which you all can review coming out of today's conversation. So I'm going to first, I'd like to ask Chris a question. So Chris is our one panelist who is not involved in this program or the partnership. And so would be interested, Chris, if you could share a little bit about your thoughts about this program and the evaluation in the broader context of health insurance and housing in Rhode Island.
Thanks a lot, Grace. And I'll offer a couple comments in response to the presentation. First of all, congratulations and thanks to One Neighborhood, to PCHC and to Faulkner for doing the work, but also for going through the discipline of evaluating it and then sharing it, kind of warts and all, in a way that allows the community to learn. I think I'm a healthcare guy as opposed to a housing guy. This is sort of the table where the housing and the healthcare people meet. But as a healthcare guy, I framed the problem that we're talking about is that we spend a whole lot of money on healthcare and we get really crappy results. That's a technical term, but it's our people live less, they have poor quality of lives, and we have enormous disparities in our health outcomes. If you're a housing person, you can find it a problem in an equally important way. We have lots of unhoused people, and that is just immoral. But I'm coming out from healthcare because there's so much money that's spent there that could be better spent for society and for folks. And there's lots of evidence that the reason for that comes from a lack of attention to what I'm sure people here are familiar with, the social determinants of health, and particularly housing. You know, the evidence is really strong that housing is such a determinant of health and healthcare expenses. I think regardless of the evidence, this study in particular is important because it's fine to know things in general, but you got to know things in a particular context, in a particular community, with a particular population. You have to understand what works. And that's why the study that we're talking about here is important. And it is, to be clear, we're applying the Willie Sutton principle. If we think that we're spending money on healthcare, we got to go Willie Sutton, rob banks, because that's where the money was. And if we're concerned about healthcare spending, you go to a high cost population. And there's lots of evidence that homeless people or formerly homeless people are where there's significant healthcare expenses. So I think this study is a success, both in understanding what works in a particular setting, and then sharing that in a way that allows folks to learn collectively about what it is that works. I think that there are a few things I would point out, and Deb and Jen talked about all of them. One is the study size is small, and so you don't want to use that as a barrier, excuse, or a stalling mechanism. But you have to be really upfront, as Deb said. The 16 is not an enormous number. I think the other thing, or another thing, we have to understand is this a test of the continuum of care model, or is it a test of what one neighborhood is doing? And that's an important distinction. And actually, when Jen and I were talking about this beforehand, it took me like about a half hour before I kind of understood, oh, you guys see this as a test of the continuum of care model in general. You know, that's very generous of one neighborhood, but maybe it's something special that one neighborhood in Providence are doing. And this can be really frustrating, because any researcher, they're like trained in graduate school that when they get done with their paper, the last thing they write is more research is needed, because it allows them to kind of continue their funding and continue to asking questions. And yet we've got to act on this stuff. And so how do we kind of acknowledge that we've got more to learn? We want to learn about it together in a community, but we've also got to act on what it is that we know so far. And so I think we can walk and chew gum at the same time. I think we can test this in other settings, in other continuum of care providers. And that's kind of a logical next step for this to go. And by the way, I should pause. I can imagine the Herculean effort to get the data use agreement signed to get this stuff. It wasn't easy. It couldn't have been done 20 years ago. So we're making progress, but acknowledge that it probably was like pulling teeth at a number of points of this. So we got to pull some more teeth. We got to do some more studies. But I think at the same time, we can start to apply what we're learning. And I think the good news is that Medicaid and federal Medicaid is making this possible. There's all sorts of ways that you can go like right up to the line and not use Medicaid money to pay for housing, but you can use it for paying for housing supports. All the services that PCHC offered can be provided. It takes work. You need to, state Medicaid needs to make sure that federal Medicaid is okay with it. And then state Medicaid and the providers have to define the codes and work through the services and bill it. But that's just sweat equity. You know, you just got to put in the time to figure that out. And I think, particularly because, as Deb said, the numbers are so big, the savings, and they're so quick. Normally, you think about long-term returns. And so I would think that, you know, if I were part of the housing community, I would frankly be beating down the doors of Medicaid and say, look, we know how to do this. Let's go figure out the support services. You get lots of negotiating about who are providers and are they licensed and what are the specific services, but that shouldn't take away from the fact that we've got those are mechanics, and we just got to work through that even as we're doing more studies. So I would argue for walking and chewing gum at the same time. And then maybe, I don't know that this is for today, but kind of the big philosophical question is, are these really medical issues? We look to Medicaid to pay for this because that's where the money is. And so, but there is a risk that we medicalize what are really social conditions, that we medicalize inequity, that we medicalize housing. And I'm not sure that folks in Rhode Island can answer that question, but we need to be aware of that, even as we look to the big healthcare pot of money to solve our social issues. So we'll sort of admit that we're stuck in, Jen used the term systems at the start. We're stuck in bigger systems that really give too much money to healthcare and not enough money to the other issues. But we can't wait around to fix that. Frankly, not when there are folks on the street who are unhoused and a lot of suffering going on. So, Grace, that's probably more than what you wanted, but I think learn, keep learning, and full speed ahead. And maybe the last thing I'll say is just, because I'm from Rhode Island, I'm in Rhode Island. There are opportunities to learn in Rhode Island that don't exist in other places. The fact that the state is so close that you can do this work, it's an advantage that other states don't have. So really glad that you're learning together and taking advantage of it and kind of full speed ahead. Thanks.
Thank you, Chris. And that was great. We could have done a whole session with just you, I think, and we would have learned just as much. So it was incredible. And I'm sure folks in the audience will have questions and want to think and talk a little bit more with some of the things that you highlighted. But next I want to bring Tom's voice into the mix. So Tom Douglas from Providence Community Health Center. So would love, Tom, for you to just share your reactions to the findings of this study, with PCHC being the supportive services provider, especially in the lens of the health center's role as an accountable entity that's really thinking and working on values-based care.
Yeah, thank you. And yeah, that was great to listen to Chris. I echo and agree with kind of all his reactions to this study. But I think we really loved seeing the results of this. I guess big takeaway is that this bridges what we had seen in national evidence around supportive housing and healthcare and their intersection to our anecdotal firsthand experience working on permanent supportive housing with One Neighborhood Builders in a very meaningful way. I am a stickler for credibility also, but I also found this to be a really powerful study when it came back. But it's hard to do those two things. You often read about these programs in two places: high-minded academic national deaggregated studies that show impacts, and then local anecdotal single case discussions where that impact seems clear, but bridging those two worlds together can be really difficult. This seemed to do this in all the ways that Deb highlighted, looking at the data, that it pushed down the things you want to push down and supported or boosted the things you would hope it would support and boost, like behavioral health, professional services. Those are all really good findings, and we're really encouraged to see those. This is hard work doing this on both sides for One Neighborhood Builders and PCHC. So I think it's also incredibly validating for those who are putting the sweat equity in to get this done, to see that it really does have meaningful demonstrative impact on cost, but seemingly clearly quality also, because the mix of services I see for the COC participants is more like what I would want for Rhode Islanders than what I see for the shelter stay population. So a lot of really good stuff there. I would also highlight, we had a really great collaborative process with Faulkner and with Grant specifically to design this, to get the data use agreement right, and to make sure we were collectively convinced up front that this was not going to be wasted effort, that we were going to see things that we could trust at the end. It certainly helped our engagement with understanding what we were going to get back, and that it was being done with some rigor and thoughtfulness around how to analyze healthcare data, so that we knew going in there were only so many participants. We talked long and hard of that in the design phase, made the outcome really exciting to see. So thank you to the Faulkner team for your work on that. It was excellent.
Thank you, Tom. And to that point, I'd like to hand it over to Grant and Deb And would love to hear a little bit more about some of the implications that you see from this evaluation for the broader field. So Chris spoke about a few, Tom did as well, but given the seat that you all sit in, would love to hear your thoughts as well.
Yeah, sure. I'll start and then I'm going to pass to Grant a little bit, but I'm where Chris looks a little more nationally, I tend to look a little more locally and how to get things like this to happen and programs like this to be funded. And I sort of start with the national perspective and say the policy window's open nationally. It's federally. It's not always open, and it's open now to support these kinds of programs through, the feds call it health related social needs. Chris called them social determinants of health, but you can fund housing supports programs through Medicaid, as Chris said, and you can do it during this administration. We can't promise the next administration federally is going to keep that window open for us. And so it's sort of this opportunity that I feel like exists currently and needs to then be supported by a state strategy. And the state strategy says, hey, if this really works, and you've got a pilot that says it works, how do you create the opportunity to fund something like this here in Rhode Island, right? And that means you've got to get state funds, you've got to get general revenue to support the federal part of this. And how do you get that, right? It's got to be, in my mind, Chris said, well, just go and get this piece to happen. I sort of feel like the opportunity is for a larger housing investment, a larger housing strategy, and say, this is a piece of it. We've got to do a bunch of things. Housing is a big component. Can we get federal authority, get excitement around federal authority, find state funds to support this, both either through braided funds of other programs, where are we spending it now, costs that are being spent now that we can call state funds, and find a way to create a package that we all can get excited about, that the state can get excited about and say, yay, hey, this is a piece of it. It's not all of it. And we should be supporting this because it's a window now federally. And there's an opportunity that this could make a difference in the Medicaid program. Grant, I don't know what else you would add to that. Sorry.
Yeah, just to add to that, as both Deb and Chris mentioned, there is this federal opportunity, and the state is pursuing it, UHHS, through their 1115 renewal. So there's opportunities for those social determinants of health programs or health related social needs to get federal support to pay for rent stabilization through Medicaid, as well as medical respite for chronically homeless people utilizing the emergency room. The state still needs to find their share of that, for that investment, and for those and needs to find adequate appropriations. But what I think this study helps to show is that it's not the state GR that you need to spend on those. It's not a pure and direct expense. There are savings that can be recouped. There is this clear ROI, return on your investment, for some of those investments in housing. You may see savings in other parts of your budget, and I think this, along with those other national studies that are comparable to this, all point in that same direction, that you do see reduction in EDs, you do see reduction in inpatient utilization, and that these results, given that we have now a local case study, I think just give, whether it's the agency or advocates or stakeholders, something to support their position that these investments can be offset with savings elsewhere.
Thanks very much. And while we have Grant off mute, I wanted to highlight one other piece, because I wanted to transition a little bit more to some nuts and bolts. And recalling Chris's comment about data use agreements and the often Herculean task that is required in order to move forward these kinds of projects. And wanted to note that really partnership with the Executive Office and Health and Human Services and their buy-in to the importance of this study was really important in order to make it happen. I was just hoping, Grant, you could say a quick word about your work with PCHC to really design the data use agreement, and how the Executive Office of Health and Human Services was a partner in that and potentially could be for other similar types of studies in the future.
Yeah, so the partnership was really between PCHC and Rhode Island Medicaid, and it was possible because PCHC was identifying the group of individuals to be looked at. So it included those who were in the continuum of care, and then a control group of those who from their EHR, their electronic health records, identified as having instances of homelessness and shelter stays. And so that created the population to be looked at. Medicaid then, and part of that DUA, the data use agreement, was clearly specifying both the populations and all the specific results that were to be looked at. So total cost of care, ED utilization, all of the slides that we went through. And so that really helps. So with EOHHS Medicaid, and then the results that they delivered back to us that allowed us to sort of do the presentation were all, de-identified. There's certain things that we couldn't look at because of small sample size when you're dealing with the 16 participants, and we had a control group of the 50 or so that had shelter stay experience. But it was just I think what helped was the clarity between PCHC and Medicaid on the data elements being used, the results that we wanted to look at, and then a willingness to accept the limits to those results in terms of the granularity of the data. I think the exciting potential is, so that was what we did was using Medicaid data. The broader EOHHS ecosystem, that includes HMIS data, it includes Medicaid data, it has a sample size of thousands of individuals who have experienced homelessness and or are getting permanent supportive housing. So it really can grow but looking at the same outputs and looking at the same results to see if this experience that we're seeing with, I think to Chris's point, is it a continuum of care outcome, or is it a one neighborhood outcome that we're observing here? You can sort of test that by looking at a broader population and universe of individuals, not just PCHC attributed lives in one neighborhood continuum of care, but those who are experiencing homelessness, those who are getting permanent supportive housing supports.
Thank you,
One thing I would
Grant.
add is the
Oh.
DOA thing is needed. You have to put that time in. So don't underestimate the time you have to do, and it's the right thing to do. That is where the hard part of this work is, although Grant makes the rest look easy. The hard part is getting everyone comfortable with what data is being shared by whom, with whom, for what purpose. And you have to do that work here. That's what's going to make this work.
Thank you both. And I think Grant's comments also spoke to that more research required question that Chris raised as well. Always more research required. I wanted to now return to Jen. Jen, from the perspective of One Neighborhood Builders, what really is the organization taking away from this study, and how might it impact our thinking or work moving forward?
Thank you. I appreciate everyone's comments previously. And one thing that I took away from what Chris had to say is this kind of notion of like plan, do, study, act, that cycle that we have to, as he said, walk and chew gum at the same time. While we are looking to investigate this, we need to continue to do it, right, and expand upon it. And that's absolutely what we're seeking to do, right? As mentioned at the project that we have in our pipeline to dedicate 40% of our apartments in our next project as permanent supportive housing. We know this makes sense from a kind of a humanitarian standpoint, but I think that the economics piece really speaks to our effort to grow the pie of resources. So beyond the ability to build Medicaid for housing stabilization services, I think that as Deb sort of pointed out, the opportunity to leverage state resources that are invested in housing to bring other Medicaid money to the table, allows us to kind of bring additional federal resources into the state. And, you know, as we're looking to the healthcare ecosystem to invest capital and housing production dollars, I think this makes the case for that. And that for me is the greatest takeaway. It's to demonstrate why this is not that isn't just a cost, right? There really is a corollary savings if you look at the meta system, as opposed to just looking at it in these silos of health and housing. But there is a savings to the entire Rhode Island state budget. And beyond, you know, so there's that economics piece, but kind of going back to that, the humanitarian side of it, it's like an incredibly, the life expectancy rates that we're seeing, that gap for people who experience homelessness, for people who are housed. And so we are spending an exorbitant amount of money to basically keep people homeless, right? And that is an unconscionable and just illogical, you know, situation that we're in. So yeah, I think that the ways that we can think about bringing those sectors together, and I know that Assistant Secretary Novaes was on the call a little while ago. I think she might have popped off, but Assistant Secretary Moore is on the call from Department of Housing, and so having you know, our leaders in the housing and the health sector together on this call, I think is really important. And this is exactly what we're trying to do, is bring these sectors who have traditionally not been in conversation together. Oh, you're muted, Grace.
Thank you. And thank you for your comments. I wanted to bring in a question that came from the chat and actually ask both Jen and Tom to talk a little bit about nuts and bolts of the permanent supportive housing program itself. So there's a question about the types of wraparound services and supports that are provided to program participants. And I think, you know, I'll prompt even an extension of that question is really how our teams have worked together to support the individuals who were served through this program.
Jen, do you want to start? Just give like an overview of it, and then I can jump in and maybe give a little more color on what the case management and PCHC side of it is.
Sure, absolutely. And you know, there's a couple colleagues from 1MB on the phone here. Karen Zuniga, who is our Director of Resident Services for One Neighborhood Builders, is really the lead on this, and she is the expert. So you know, you can put in the chat, Karen, if I mess this up. But so the partnership is really One Neighborhood Builders is the owner of the apartments. We partner with a third-party property management company called PVD Properties that does the conventional rent collection and maintenance. We, as the owner, oversee that property management company and make sure that they are doing their job thoughtfully and consistently. And then we employ resident service coordinators. So those are the team members that report into Karen. And they kind of are the liaison between Providence Community Health Centers that provides more of the clinical services, and our property management company that does the lease compliance and rent collections and maintenance, and our own resident services team that sort of provides eviction prevention resources and convenes the conversation with PCHC to really do kind of weekly case conferences of the residents. It is exceptionally high touch. While, you know, yes, we can say that this is a small group of people for a study, only 16. These 16 individuals do represent an outside service need relative to the rest of One Neighborhood Builders portfolio of residents, because of these intensive behavioral health and mental health diagnoses. So Tom, I don't know if you want to talk about how you provide those services and what your team looks like at PCHC.
Yeah, thank you. So we have our case management team deeply involved in this program on an on-site basis. They are physically at the apartments, doing their work as often as they can. At a high level, from a broad description sense, they're advocating for and helping these residents get access to the medical behavioral health services that they need, prescriptions and all of those things. In practice, you can imagine that's a complex and varied thing, because we're talking about a wide range of people who have a perhaps different history of accessing the healthcare system than we do. They may not necessarily feel ready for all of the things that we might recommend for them, and that can be a slow journey. You can imagine also that serving this population appropriately is both really high touch from a housing perspective and really high touch from a health perspective, and issues that exist on the seams, the lines aren't always really clear. So something I'd really like to emphasize and compliment the teams that work on this on both sides is they really do have to have a lot of creativity, a lot of patience, a lot of willingness to try to figure something new out under stressful circumstances. It often requires extra hours and team support and late phone calls and all of those things. And so it's cool work to see firsthand. But yeah, I hope that answers some of the question. I can give more details if needed, but that's generally the theme of it, is the two of our organizations working collaboratively, but trying to figure out what side of the sandbox we should stay on to support these residents and patients as completely as we can.
Thank you both. I'm going to ask one follow-up question to that. As I do, I want to remind everyone to feel free to plop questions in the chat, and also to preview that after I ask this follow-up question, I'm going to open it up. So get your questions ready. So this, I think, is still for Jen and Tom, but everyone else feel free to chime in if you like. We've been talking a little bit, we talked about the study, barriers to doing more studies. Now we're talking about the program. And in addition to resources, financial resources, I'm curious if you both can speak to any other barriers you see, opportunities for growth or for overcoming those barriers to do more permanent supportive housing. Like, what's standing in our way as a sector, as sectors that work together, and as a state?
Yeah, I'll take an initial stab at that. I think Chris spoke to it earlier. I'm going to re-highlight it, that there's seams in the purse strings in some of these programs that are important to understand. They shouldn't be ultimate roadblocks, but they are important, I think, to break down some of these walls. For those of us that are on the healthcare side, we think about this in terms of dual eligibles a lot, patients that are on both Medicare and Medicaid, and the way that those two programs, even though they're both providing healthcare services, cause care to become fragmented and communication to fail, and that we are working diligently at how to undo that, simply because we're paying for part of it out of one side of the budget and part of it out of the other. Healthcare and housing is a slightly more complicated version of that, and the seams are sometimes a little harder to see, or perhaps but harmful and costly also. I think when we talk about where this needs to go, it's continuing to really focus on that, and to continue to innovate at all levels, both in kind of how we deliver it, but also how we fund and think about these programs from the top, because often those are the barriers for us to be able to move forward, is, the difficulties of getting all legal opinions on the same page at one time at 6 different organizations, stuff like that. And so that does require, I think, those of us on the more bureaucratic side of things, on the funding side of things, to remember that we've got to work as hard as the people in the apartments do to get the stuff done, and push. And so that to me is the biggest takeaway, is to continue to open the doors for more people to try programs.
I'll just add a quick addendum to what Tom said, but completely agree with that response, So ultimately, there's three legs of the stool, right? There's quality service providers, there's a rental subsidy, and then there's the actual like physical unit of housing. And for a long time, the challenge that I think we faced was inadequate rental subsidies. That has shifted. I think right now, if you talk to people, they will say the greatest impediment to scaling up permanent supportive housing is a lack of units. We actually just don't physically have enough apartments to house the people that we need to house. And we actually have rental subsidies that are available that people have got the golden ticket and they can't utilize, and they have to give them back, which is really a tragedy. I think that also for the first time, there's a mechanism to pay for housing stabilization services. Prior Medicaid waivers have been successful, and now we can bill for the services that we provide. I think that on that piece, there needs to be vastly more training to kind of mainstream medical and behavioral mental health providers in housing first methodology. So I think that training kind of the healthcare system and understanding housing first home-based care is really important. I should say that's a challenge that we need to address as a state. But I think that most prominently, it's a lack of physical housing.
Thank you. Okay, I'm gonna open it wide up for questions. So if you want to come off mute and state a question, please feel free. Andrea?
Yes, hi, good morning. Thank you so much for this presentation. It has been very, very educational, and I'm very, very excited to hear about this project. I am currently working as a consultant with a large housing agency, and they are located in one of the cities with the worst homeless issues in the country. And one of the challenges we have been facing in helping identify or optimize the way they have been running their programs is that it seems that the continuum of care is very difficult to navigate, not only for participants, but also like among all the member organizations. Like the communication has been very segmented, and it's very hard to get everyone on the same page. So I was wondering, what has been your method, or if you guys can provide any best practice to facilitate and optimize the process, of getting everyone on the same page.
Thank you for your question. It's a hard one. I don't know if Jen, you want to say just a quick note about the work required with us and our partners, ranging from Rhode Island Housing and PCHC, other partners we work with, because my understanding of the shorthand is I don't think we have a silver bullet, but maybe Jen, you can say a little bit about what that work looks like to get on the same page.
Yeah, no, we definitely don't have a silver bullet. If we did, though, wow, like there would be like 50,000 people on this Fresh Friday, not 56. But I think that this is just an endemic problem. I mean, ultimately, we know that the solution to homelessness is a home. That is it, right? And having individuals who are, or organizations who are working as homeless outreach providers, and organizations who are providing services, and organizations who are providing housing, we can't possibly not be talking to one another, because together we hold the solution, and any one of us alone is not providing a solution. So I think it's just like hard work and communication. There really is not something magical there. We know the solution. We just have to work hard to do it. I wish I could provide maybe a more, insightful response, but it seems like it's really just the obvious hard work of recognizing that alone we don't have the solution, but only together do we.
Thank you.
Thanks very much. Any other questions? Feel free to shout them out. I'm going to raise one that is in the chat, which is just, does anyone on the call here who can speak about other places that they have seen that are doing a great job at integrating housing and healthcare, budgeting and planning, and who we might be learning from? So I don't know, Chris, if you have any insight, or perhaps Deb or Grant, just into other models that might be useful for folks here in Rhode Island to think about.
I'm not familiar enough to point to a specific model, Grace. I think that Jennifer's sort of analysis of the challenges and the issues is spot on. There is the solution to homelessness is a home, and the work that PCHC is doing in the continuum of care is necessary but not sufficient. You need these other resources. I am encouraged by, and I know One Neighborhood and other folks in the housing community have worked hard on this, that you've been able to prioritize the housing issue within Rhode Island in terms of getting increased legislative attention to it and just an advocacy support. But gosh, Grace, I try to come up with a specific place to point. I think it's no, you gotta keep working at it the way that Jennifer said. I don't think anyone else has got a particular, and well, I would say this is a long trajectory. We didn't get into the housing issue crisis in Rhode Island overnight. And so we've got the supportive housing resources that we're talking about today are one piece, and what's got to be a much longer commitment around, I think, frankly, it gets to just things that way beyond housing, how our democracy works, how our civic processes work, so these concerns remain front and center. Thanks.
Thank you.
Hard to follow that, but I would just add a much narrower, which is to say states are doing, a lot of states have been successful at implementing permanent supportive housing, these kinds of programs through the Medicaid funding, through the what CMS is calling health-related social needs, getting authority to fund these kinds of very specific programs in support of their Medicaid agencies because they save money. So California, Massachusetts, I think there's a list, maybe 6 or 8 of them now, that have been successful at, very specific approaches of integrated programs that are funded by Medicaid. So that's not solving the housing problem, right? To Chris's point, it's not, it's not the larger solution, but it opens the door, right? And it creates a pathway.
Thanks very much to you both. And I see in the chat, Chris Ashura from EOHHS has dropped a resource from Oregon, it appears, so folks can do some additional reading following today's conversation. Any other questions from the audience? I'd like to ask maybe 1 or 2 closing questions here as we're nearing 10 o'clock, which is for the whole group. What questions are you left with from this evaluation, and what are you most excited about us as a sector, as a region, really digging into and understanding next?
I would love to, and so I'm actually a data geek myself, I gotta say. And so I would love to be able to look at the COC program across the state, and there's about 250 COC units currently and in place. And is there a notable difference in the results for head of households or single adults versus families. I would love to kind of stratify the analysis based on that.
And I would, I guess I go back to the comments I made at the start. It's this walking and chewing gum at the same time. And if part of this is learning Jen's question about, how does it affect different homeless populations and different interventions? There's got to be it can be dispiriting to do the stuff that Tom was talking about, to work through the billing, to, the dual eligible can just be like a complete stop. The role of the managed care plan. And there needs to be, I think, none of those are insurmountable. They just require real administrative persistence and cleverness. and that's kind of what we got to see to address these things. Yes, we can make it can be certainly made easier. The barriers can be reduced, but they can be overcome. They just got to be, and when I'm talking about the billing, the administrative issues, the data use agreements, you just got to keep the pressure on and keep it at the top of the list to work through these things, because it's too easy to have meeting after meeting and meeting notes and nothing ever happens. And so you gotta have some bureaucracy busters on your team.
Thank you. Deb, Grant, Tom, final word on the question I asked, or any other question that you want to answer?
I guess just that we really appreciate both working on the program with One Neighborhood Builders and on this study and this collaboration. We're really encouraged by it. I think it provided some good oxygen to the team that's doing the hard work to be able to look at these slides and say, yeah, this is real, meaningful, tangible stuff that made a difference. So that's not always easy to do. These folks usually do that work without that. So that was really cool to see. We're going to put our bureaucracy buster hats on. That's kind of been PCHC's mission for a really long time. So we're going to keep after that. I really appreciate everyone coming to listen to this work today. Thanks.
I'll just say the same. And one thing I'll say is, we work really hard to be independent and neutral, and came into this with an expectation that, we'll see what it says. And, we were surprised at how strong these results were for a very small sample. So as an independent party, I just want to say, nice work, like you did something here. Now maybe it'll be replicable. We'll have to figure out how, and you have to keep plugging, but nice work.
Yeah, I'm always dubious about these kind of interventions, and I warned Jen and Grace at length at the start to that fact. But overall, it was just a fascinating study. And to Tom's point, like to actually see the results, even with with a tangible group, is encouraging, and it makes the research fun in a way. And also working with EOHHS and Medicaid and seeing like the data that they have through the ecosystem and with HMIS, like the opportunities are there to expand this to a much broader pool of individuals.
Thank you all so much. Just want to take an opportunity to thank all of the panelists for their time and insight and expertise this morning. I also want to thank members of the One Neighborhood Builders team who are both on this call and not, who are critical both to the work that we've been studying and the study itself. So my colleague Ali Steinberg, who's been involved in this study from the start and really made this Fresh Fridays happen this morning. Karen Zuniga, who Jen mentioned earlier, who leads our resident services work, as well as Dennis, Claudia, and Martine, I think some of whom are on the call here. So truly credit goes to those members of our team for their hard work over the last few years. And really want to thank everyone else on the call who made time out of their Friday morning to come and learn with us and engage in a conversation We will be, there's a link in the chat right now to a page on our site, on our website, that includes a press release we did about the report this morning. It will be updated with a link to the report shortly. And then we will also be sure to send the full report to everyone who attended today's session. So you'll have a chance to dig in from there. And we'll be having some more Fresh Fridays in the months to come. So look forward to announcements about other topics that we'll be investigating with friends and colleagues here. And last note, as you leave the Zoom this morning, in your browser will pop up a little survey for you to complete about your experience on the session this morning. So if you have any feedback or thoughts or ideas about things we might discuss in the future, please feel free to take a moment to complete that very brief survey. Thanks, everyone. Have a great Friday.